Cervical cancer is one of the great success stories of medicine. Screening in developed countries has meant that its incidence has more than halved, and then we got the vaccine to HPV. HPV is the cause of cervical cancer, in particular types 16 and 18, and now we can vaccinate against them. Let's take a look for a moment at the world's deadliest viruses. Here they are. And HPV is number 6. But what's really interesting is if we look at which viruses can be vaccinated for, there are 4 of them in this top killer list. In this video lecture, we're going to be thinking about cervical dysplasia and how it progresses to squamous cell carcinoma of the cervix. And then we're going to be thinking about adenocarcinoma and its similar relationship to adenocarcinoma of the cervix. Here's your first key fact about cervical cancer. It's caused by HPV. Second, it develops from cervical intraepithelial neoplasia. Now, the grade of the CIN depends on the proportion of epithelium occupied by atypical cells. The atypical cells show the typical features that we associate with malignancy: an increased nuclear cytoplasmic ratio, loss of polarity, the presence of mitotic figures, and pleomorphism. This diagram explains the concept. So in normal epithelium, what we have is dark basal type cells confined to the bottom 1 or 2 rows of the cervical epithelium. As we progress through the grades of CIN, the proportion of those dark, ugly-looking cells occupying the epithelium increases. So in CIN1, they occupy 1/3 of the epithelium. In CIN2, 2/3, and in CIN3, the total thickness of the epithelium. The difference between CIN in situ neoplasia and invasive cancer is shown on the left of the diagram. In squamous cell carcinoma, we have a breach of the basement membrane and the malignant cells invade through. Most low-grade CIN will spontaneously regress. 90% of CIN1 will regress within 2 years, and 50% of CIN2 will regress within 2 years. This is why in the screening program, people with CIN1 are rescreened, because we know most of it will go away. If CIN is watched and left untreated, then the 10% of CIN1 that doesn't resolve will persist, and some of that will move on to become CIN3. It's likely in these cases that the CIN1 was being caused by infection by a high-risk virus, which has now integrated its DNA into the host genome and caused CIN3. If a woman has CIN3, then about 20% of it will progress to squamous cell carcinoma over 10 years. In other words, there's about a 2% risk per year of getting squamous cell carcinoma. The time to progression is typically about 15 years, and that's why it's okay to start screening at 25 or 30. Because the highest risk for cervical carcinoma is in women over the age of 40. The outcome for cervical carcinoma, like many cancers, depends on the stage, i.e. how far the cancer has spread. This makes it vital to detect any cancers early. What makes up stage in cervical carcinoma? The first thing is the size and depth of invasion. The second is lymph node involvement. The figures to my right show how important stage is in determining clinical outcome. If the cancer is confined to the cervix, then there's a 90 to 95% 5-year survival, but if it's spread to the lymph nodes, only a 30% 5-year survival. Here are some more key facts about cervical cancer. HPV 16 and 18 cause 70% of cervical cancer in New Zealand. 150 women in New Zealand contract cervical cancer every year, and about 55 women die from it every year. Maori women have twice the chance of getting cervical cancer, and their mortality rate is 2.5 times that of non-Maori women. Cervical cancer is much more common in less developed countries because they don't have screening programs. How does squamous cell carcinoma begin? The diagram on the right shows dark blue cells, which are CIN3, and they're filling up the glands in the cervix. And then one little group of cells has developed the ability to break through the basement membrane and start invading the underlying stroma. And that's how squamous cell carcinoma starts. Let's think now about adenocarcinoma. This is also HPV related. Similar to squamous cell carcinoma, there is a precursor lesion, adenocarcinoma in situ. In this, the neoplastic glandular cells are confined to the pre-existing glands. They also can develop the ability to spread into the stroma, and this invasive adenocarcinoma has infiltrating neoplastic glands. Adenocarcinoma comprises about 20% of tumours in a screened population, as opposed to 5% in an unscreened population. This is because the screening program is excellent at picking up squamous cell carcinoma on Pap smears, but less good at picking up adenocarcinoma in situ, which is buried well up the endocervical canal. These are the key facts that you need to remember about adenocarcinoma of the cervix. It forms 20% of cervical carcinomas in New Zealand. In unscreened populations, it forms 5% of cervical cancer. It's also caused by HPV, and it's picked up less well by cervical smears. In this talk, we've learned that cervical dysplasia is caused by HPV and is a precursor to squamous cell carcinoma of the cervix. Similarly, adenocarcinoma in situ is caused by HPV and is a precursor to adenocarcinoma of the cervix. The rapid progression in knowledge and treatment of HPV has meant that we have the possibility of eliminating cervical carcinoma from our populations by 2050. Encourage the women in your lives to get screened and vaccinated. And vaccinations also now available for boys. This will prevent carcinoma of their genital tract, but also carcinomas of the head and neck. Did you know that about 1/4 of all cancers of the head and neck are HPV related? Get those vaccines.